How did a week already go by?
That's what we said. How did a week go by like so fast? It just, it was a blink. Ask a weird question before we get started, Doc. This is not blush, and I don't usually have acne, but I have been for weeks and weeks. I get these pink bumps all across both cheeks and up to here. And it lasts about 2 weeks. It goes away. It comes back in about 2 months and it goes through the cycle again. I don't know if that's lupus related or
well, in some circles, they call that the butterfly rash of lupus.
Yeah.
I was going to say butterfly. Right.
The post-viral autoimmunity of Epstein-Barr and the rest of them gives you an autoimmune disorder, which is either is lupus or very similar to lupus. But that's the first thing you think of in that place where it gets red and what have you, comes and goes. Yeah, the famous butterfly rash.
I've always had the trouble of distinguishing what is happening because so many things overlap one another and the symptoms overlap each other. But I cannot mistake an AA flare up. That's a different bear. So yeah.
I'd like to know why my cheek gets red when I take a steroid. Just the one cheek gets red every time I take methoprednisone.
You didn't get enough kisses on the other cheek when you were young.
That could possibly be it. Oh, still don't.
Valentine's Day is coming up. You got to get ready.
That's right. Well, you're no help at all.
That's not the first time I've heard that.
He's just telling you to turn the other cheek.
Yeah. I think it's just strange. It's one cheek every time I take it. Weird.
Just glad to still be kicking, and I'm glad you all are still with us too.
Me too.
Yeah.
I'm glad you're with us.
Thank you. Glad to be with you all. Welcome everyone to Doc Talks with Dr. Forrest Tennant and friends. This is season 5, episode 4. Thank you so much, Doc. It's all yours. Please take it away. Thank you.
Yeah. Well, thank you, Jamie. I'm delighted to be here. We're going to have a great session today. We've got one of our good regular guests and advocates, and Alison Guyton's going to be with us in a little bit. Somebody asked about the back of the wall where I'm at. Besides my medical work, I have for many years developed some collections. I started off with antique shoehorns, and then I started collecting memorabilia from the Roaring '20s. And you're in the Roaring '20s room. Now, you can see some things from the Roaring '20s behind me. If I was reversed, you'd get to see all the pantyhose and some of the other things from the Roaring '20s. But sometimes I do this show from another room called the Buster Brown Room. So you'll get a chance to maybe to see my other life. So at any rate, tonight we're going to have a good show. But I want to start off with something tonight that is critically important, and it's my presentation here is being backed up by a bulletin that our receivers will get, entitled "The Reason We Use a Medrol 6-Day Dose Pack to Diagnose Inflammation in Severe Pain." Now, a lot of you out there have had probably what's called a 6-day Medrol dose pack. Now, let me back up and explain a few things that are critical in the management of particularly your viral-induced autoimmunities, your arachnoiditis, your CRPS, your small fiber neuropathies, and that is, where do the corticosteroids fit and what are they all about? Now, we'll start off by saying that for good or for bad, corticosteroids don't have a very good name out there in either the medical practitioner community or in the patient community. And that is because they're very poorly misunderstood and very poorly prescribed. However, and you're going to have to understand this thoroughly, we cannot manage autoimmunity. We cannot manage your autoimmune diseases such as adhesive arachnoiditis, small fiber neuropathies, CRPS, pudendal neuropathies without corticosteroids. We cannot do so. Why? Because corticosteroids in the body have the functions of suppressing inflammation, and also, surprisingly to a lot of people, corticosteroids are a co-partner with the endorphin receptors, your opioid receptors. So if you don't have enough corticosteroids in your blood, you can take all the opioids in the world and they probably won't work. So you've got to understand that these two functions of corticosteroids are critical. So what about Medrol, and what is the situation here? Well, it turns out that there are about 13 corticosteroids, and the one that everybody knows about is plain cortisone, and it's made in the adrenal glands, and it can be called hydrocortisone, it can be called cortisol, or it can be called cortisone. Now, plain cortisone has a lot of side effects if you take it, and it has very little use in pain treatment. The corticosteroids, however, that do have a place are really two. One is Medrol, and that's methylprednisolone, chemical name methylprednisolone, and the trade name is Medrol. The other one is dexamethasone, sometimes just called Dex. And a third one is prednisone, which is the most commonly prescribed corticosteroids. But there's a problem with prednisone. Now, let me tell you what the problem is. Only 2 of the dozen corticosteroids cross the blood-brain barrier, and that is either the methylprednisolone or dexamethasone. Prednisone doesn't cross very well. So therefore, people who are trying to treat adhesive arachnoiditis, multiple sclerosis, centralized pain, you're not going to get very far with prednisone because it simply doesn't get into the spinal fluid or into the brain and spinal cord in a high enough concentration to do much good. It's great if you're trying to treat arthritis or myositis or neuritis outside the spinal cord and brain. It works quite well. But it's not going to work if you're trying to treat a condition inside the spinal canal or inside the brain. You've got to use either Medrol or dexamethasone to do that. Now, something else has been discovered, which is very interesting. In the brain and spinal cord, there are what's known as receptors for methylprednisolone and for dexamethasone. And so you have 2 things going. You have the fact that these 2 corticosteroids will cross the blood-brain barrier and get into the brain and spinal fluid. Plus, there are specific receptors that these corticosteroids activate to give you healing. And so, if you've got a disease that's inside the spinal canal, like arachnoiditis or chronic cauda equina inflammation, or you've got central autoimmunity, you're going to need one of these 2 corticosteroids. Okay. Now let's carry on real quickly on something else. These corticosteroids have gotten a bad name because they've been taken every day. If you cannot take a corticosteroid every day for 10 days, or you're going to be sorry, you're going to have side effects. And you don't want to be taking these corticosteroids every day unless it's a life-saving situation, okay? Now, let's go back to the Medrol dose pack. Now, keep in mind, Medrol is just the trade name for methylprednisolone. Now, the 6-day Medrol dose pack should be very familiar to you as a patient who has intractable pain, regardless of your cause. Now, why is that? Now, I'm going to give you a simple thing about pain that's not appreciated because people are always trying to assign a new definition to pain. Nociceptive, high impact, persistent, they try to label it. but the fact is that there are three things that cause pain. Now let's go over these three things. One is inflammation of the nerves or nervous tissue. Okay, inflammation. The second thing is that the nerves or the receptors have degenerated and are damaged or they don't exist. Small fiber neuropathies are when you have literally caused these small fibers to disappear. In other words, the nerve is non-functional because it's degenerated. Now, the third cause of pain is when a nerve is either compressed or it's entrapped. Now, a common one is when a disc, for example, in the spine presses or compresses a nerve root. Yeah, that'll give you pain. In adhesive arachnoiditis, we have a real problem because that's actually a mass that entraps the caudo-equina nerves inside this inflammatory adhesive little ball, if you will, or little mass or clump. Okay, now if you have a compressed nerve or a entrapped nerve, you may need surgery. And so that's why we do that. Okay, so let's go over that again. If you have pain, you've got either one or all three of three conditions. You've got a inflammation of your nerves or nervous tissue, or your arachnoid, something like that. Or number two, you have got degeneration of the nerve or receptor or complete disappearance of the nerve or receptor. And if you have total disappearance, bioelectricity backs up and can't pass, so it causes pain. Or thirdly, you can have your nerve entrapped or embedded, if you will, in some kind of tissue, or it's pressed upon. And so that also backs up electricity, doesn't allow electricity to pass, and that causes pain. So what does the Medrol dose pack do? The Medrol dose pack lasts 6 days, and I'm sure a lot of you have taken it. It's already set up. Every pharmacist knows about it. It is standard medical care and good medical care in 99% of the cases. Every nurse practitioner, doctor, osteopath knows about this, okay? And they're willing to fill this for 6 days because they know that's quite safe. Why are you giving it for 6 days? You're doing it for two reasons. One is therapeutics, maybe to get better, but the real reason is to determine if your pain is due to inflammation. Now, this might surprise you. You've heard me on this show talk about inflammatory markers. C-reactive protein, erythrocyte sedimentation rate, the cytokines and the leukotrienes. But guess what? A 6-day Medrol dose pack is a better test for inflammation than those blood markers. Why? Just like the rash on your face, Jamie, it comes and goes. Inflammation comes and goes in the serum, but it can be right there in your nerves, okay? It can be intracellular or extracellular. And so a blood test isn't as accurate in determining if you have inflammation as is the 6-day Medrol dose pack. So here's what happens. You take the 6-day Medrol dose pack, and if you do have adhesive arachnoiditis or one of the CRPS, here's what's going to happen. Over this 6-day period, first off, your pain's probably got to get better, hopefully, if the inflammation is being suppressed. Maybe you're going to get more energy, you're going to get more sleep, your appetite's going to get better. Maybe your legs are going to flex better. Maybe you're going to have stronger muscles. Maybe your bladder and your bowel will work better. In other words, if your pain problem is due to inflammation, the 6-day Medrol dose pack will give you some clinical improvements. Okay? If you made the diagnosis, you've got chronic inflammation that must be suppressed. So what do you do after the 6 days? You go right on to a program in which you're taking a low intermittent dose of Medrol, for example, 4 milligrams 2 or 3 days a week. So you go right into that. If you just stop after the 6-day Medrol dose pack, the inflammation is just going to come right back and you're going to be right back where you were. Okay? Now, let's go on for a minute. What if you take the 6-day Bedroll dose pack and you don't get better? What you have then diagnosed is that you've got degenerated nerves and or receptors. They're not working. They're damaged or they're gone, one of the two. Or thirdly, you've got some nerve that's being compressed or entrapped in some kind of tissue, or it's being pressed on by a disc. In other words, it's a compression type pain. Okay, now let's go on for the next thing that we want to talk about. Another thing that I'm sure that 90% of you watching this have experienced, and that your doctors today have been trained to try to manage pain with what's called a neuropathic agent. Okay? Now, neuropathic in the old days just meant a damaged nerve. Today, it still means the same thing, but there is a class of drugs that are called neuropathic agents. Okay? Now, they're called neuropathic agents because they do enhance or help the electrical conduction move up and down the nerves. In other words, if the nerve is damaged, maybe it'll help get around the damaged area. If the nerve is entrapped, maybe it'll get the electricity past the entrapped area. And it'll try to activate or attach a neurotransmitter called gamma aminobutyric acid to its receptor. So these agents are given all the time. Now, they're poorly understood. I think the most misunderstood thing is that, number one, benzodiazepines are too dangerous to prescribe, and number two, you can cure all pain with gabapentin. Now, I mean, these things have been out there like, I don't know where it came from. First off, I just defy anybody to tell me all these hazards have occurred with a 2 or 5 milligram Valium tablet. Okay? I mean, a 2 or 5, 10 milligram Valium tablet, as far as I can see, there isn't a better neuropathic agent come along yet. Soma today is an excellent neuropathic agent. You'd think that some people are saying that is so dangerous and abusable it should never be prescribed or even be on the market. I don't know where this nonsense came from, because these drugs can be taken very, very safely. But the neuropathic agent of today of choice is gabapentin or Neurontin. And doctors have been pushing the dosages on that clear on up into the 1,000, 2,000, 3,000. People are walking around like zombies. That can be abused just like any other drug. And so gabapentin in a dosage, let's say up to 600, 800, 1,000 milligrams a day may be very helpful. But when you start going above that, I just wonder if the side effects aren't worse than the cure. Some people do well. Now, I want to talk about another thing about these neuropathic agents for a moment, because, and I want everybody to understand this, if you do have intractable pain due to inflammation, nerve degeneration, entrapment, you're going to need one or more of these agents, okay? You're going to need these things. Now, let me give you the common ones out there. I think I've mentioned Soma, I've mentioned Valium, I've mentioned gabapentin. Xanax is excellent. Ativan, one of the new kids on the block, is pregabalin. The trade name is Lyrica. And baclofin's another one out there that's being prescribed. So those are the prescription neuropathic agents that are popular right now. Okay, now I've said that, I also want to talk for a moment about non-prescription neuropathic or GABA agents. Okay? Just like with the opioids, we have in some parts of the United States this drive to get doctors to stop prescribing benzodiazepines and Soma and take everybody off those just like opioids. And I'm very well aware, and I know Dr. Ibsen can weigh in on this. We've seen people commit suicide when they're taking off their Valiums or their Xanaxes too rapidly, just like with opioids. It's a dangerous situation to stop those, but you've got to have them to deal with severe pain. Now, there are 3 natural herbal GABA or neuropathic agents. One is Kava. A second one is Valerian root. And the third one is kind of a new kid on the block called Ashwagandha. Okay? Now, you might want to write down Ashwagandha. Here is one message I want to give to everybody out there. If your doctors are pulling your Valium, pulling your Xanax, casting you off your neuropathic agents, then don't just sit there and take it. Get some of these natural agents, and you can also supplement those with amino acids, taurine or glutamine from the health food store. But don't just try to come off these agents cold. It's dangerous. It's far more dangerous than coming off opioids, okay?
Yes.
And you can go and you can get Kava, you can get Valerian root, and you can get Ashwagandha. And in fact, if you can't get your Valium or your Xanax, and that's been a lifesaver for you for over the years, try to mix and match these natural agents and see if you can't make your own Valium. It is, sometimes a person can do that. Now, before we call on Dr. Ibsen to weigh in on this benzodiazepine issue, I want to say one other thing about ashwagandha. Ashwagandha. I'm becoming an ashwagandha pom-pom girl. I'm all for it. Let's take a little of it. I'm going to tell you why. I have here an article that's pretty new, and it's called Update of Natural Products and Their Derivatives Targeting Epstein-Barr Infection. Okay, and guess what? Ashwagandha also suppresses the Epstein-Barr virus. So you're getting two birds with one stone here. You're suppressing the Epstein-Barr virus and you're getting some pain relief with ashwagandha. That's why I say go ashwagandha, okay? Give it a go. It's cheap. You can get it down at any health food store or on the internet. On most of these natural and herbal products, start with the label that's on the bottle. And in most cases, if you've got severe pain, you're going to have to double or triple the dosage. But start off with what's on the label, then you can go up. Anyway, Mark, before we go on, I'd like your comments about the benzodiazepine hysteria. And I call it plain hysteria. I mean, Valium has been around since 1964, and all of a sudden, it's the most dangerous thing that came down the pike. Give us your rendition of benzodiazepines and what people should do about it.
Before I do, I'm not an expert in benzos, but I've developed expertise in gabapentin, and I want to spend just a second or two on that.
Good.
I have no problem when gabapentin helps people. However, it has become, it is indicated for two things: post-herpetic neuralgia, that is the neuropathy that happens after having shingles, and diabetic peripheral neuropathy, the neuropathic pain that happens with diabetes. Those are the two indications. That is a small population. I mean, there's a lot of people with diabetes, but gabapentin is being used as the primary pain medication across the board for everything. First choice, first call on everything. Now, what I've noticed about that is, and particularly being involved with cannabis, is that cannabis can do everything gabapentin can do, but without the side effects. And here there are the 5 side effects: brain fog, memory loss, weight gain, depression, suicide. Oh, there's 2 more. Blurred vision and balance issues. I have people that I've talked to who stop reading books. Well, everybody stopped reading books these days anyway, but people who've stopped reading books because when they're on chapter 5, they can't remember what was in chapter 3. So the memory loss with gabapentin can be dramatic. People think they're demented and they're already old, and they think, oh, my brain doesn't work because I'm old. And it's like, well, that's when you need every boost you can get in your brain function. And the thing that's not proven about gabapentin, but I have a hunch about it, I think we're going to find out it's associated with or causative for dementia. So it interrupts enough synapses that you don't want interrupted, that if you can avoid it, it's great. Now, I do have some patients who are on it and they swear by it and they love it and
Yep.
they keep their dose low, and I'm all for it as long as it's not causing one of those 7 side effects. But I think it behooves us to warn our patients that these side effects are possible, and no one knows about these side effects. No one's talking about it, and that's one of the criminal effects of pushing gabapentin. Now, as far as the benzos goes, I actually defer to you, Dr. Tennant. I mean, I stopped using benzos a long time ago because the fear of benzos was worse than the fear of pain and pain management. The
Yeah.
typical Rolling Stones song, Mother's Little Helper, with using benzos for the angst of the intense life that we have in our first world country. And so it had some negatives for me from when I was a teenager listening to the Stones. So I'm newly re-examining my use of benzodiazepines with patients in pain, and I have found that what you say is true. It is a potentiator of pain relief and leads to less benzo use as well as less opiate use. So it's definitely complementary, not harmful. And where does this fear of benzos come from? Well, it comes from street drug abuse. People who take their benzos appropriately, they may become dependent on it and they may require some tapering, or they may have trouble, they may go into withdrawal if they lose access. It seems like Xanax is tougher to get off than Valium is. Um, um, but I now believe it's much more complementary to be using those medications, particularly in the refugee population I'm taking care of. And you have to realize that you want to put up with the side effect of dependence if you're getting great results, and deal with the dependence later if you have to. We use chemotherapy with lots of side effects for people in cancer, and we put up with those side effects. In fact, we have a contest between the cancer and the side effects, and whoever wins wins. And sometimes the side effects kill patients. So it's noble in cancer treatment to treat with high side effect medications, fight that cancer. William just fought his cancer to the end and it killed him, but he put up a good fight. Now, those of us who are putting up a good fight with pain, for some reason, we're not so noble. I don't understand that. And we will get to the bottom of that eventually. I think it has to do with fear of badness, and I've talked about that before. If gabapentin helps, yes. We use the scientific model with each individual patient in a sacred physician-patient relationship. If it works for you and you're not having the side effects I warn you about, then by all means use it. Adding in Valium is great, and I love what you said about Kava and Valerian, and now I know this about ashwagandha too. Thank you. Those are relaxing agents. They're smooth muscle relaxers in addition to GABA augmenters. So, for example, Kava is a great herb to use for kidney stones. It relaxes the ureter so that you can pass a kidney stone. So who knew that? I mean, I didn't find that out until I had my urgent care co-located
expert, yeah.
co-located with a with a naturopathic clinic. So my naturopathic friends taught me that. So there's really room to go back and forth with our different philosophies. But for sure, we're being forced to invent our own relaxing agents, and part of that is the advantage of meditation. And a lot of people in the pain community, and a lot of my patients really don't want to hear anything about you can meditate your pain away. And I agree that if your pain is an 8, you're not going to meditate it away. But there are techniques to handle our anxiety. There are techniques to get smooth muscle relaxation happening. Massage is another one of them. So we can use those techniques. They're not a be-all and end-all solution. We just have to have little incremental changes and include them as much as we can.
Jamie, let's bottle this last lecture we just got, okay? That's great. Thanks, Mark. Right on, right on. Do we have Allison handy here that we can bring her on? She's also got a lot of experience with all of this stuff too.
Yes, I'm
Have we got-
here.
Oh, you're there, okay.
I am
How you doing?
here and I'm busting at the seams. We've been talking about everything that I have been researching.
Yeah, I know you have. No one
Uh,
researches more than you.
I'm
Yeah.
telling you, well, I was on methotrexate and didn't realize that it was killing my heart with our autonomic dysfunction that intractable pain causes. With it wiping out our hormonal system from the pituitary gland to our adrenal glands, and then the excess electrical stuff. You had a Chronicle 16 out, and it's also in your awesome little intractable pain handbook. But all in all, it ends up causing autonomic dysfunction with vasoconstriction and the Raynaud's in the small nerve neuropathy and all that kind of stuff. But it causes coronary artery constrictions. So that's what the methotrexate was doing. I would have what I just labeled them intractable pain syndrome attacks, where I would be absolutely soaking wet, sweating profusely, trembling, couldn't find words to speak, and I was stuttering if I tried to speak, just from standing up in the kitchen and, bebopping between the sink and the stove and the refrigerator and just trying to cook a normal dinner. So that has stopped at this point. But I realized that it was the autonomic neuropathy or autonomic dysfunction, fight or flight syndrome that the intractable pain puts us into. So the methotrexate caused that vasoconstriction to be constant with me, and my heart was aching all the time. Not angina really, just kind of my heart was aching. So I knew something was up, and I Googled it, and sure enough, it causes vasospasms. So I immediately came off of it and started researching all of the medications that I was on to make sure none of them were doing any further harm. And that's when I found I was already taking L-Arginine because it's known to help strengthen the dura in our meninges to try and help with having CSF leaks. But it also helps the endothelial cells that line all of your arteries, whether it's your cardiac arteries, your renal arteries, all of them comes down to a cellular level, and they utilize nitric oxide to cause vasodilation. So it just has the opposite effect of, and helps us with our autonomic dysfunction. So the methotrexate was a double whammy. I already had severe autonomic dysfunction, and then the methotrexate was killing it even worse. So I
Alison, why did your doctors and you decide you wanted to try the methotrexate?
I saw a rheumatologist at the University of Tennessee the end of September, and she diagnosed me with limited scleroderma, earlier known as CREST syndrome. I'm not sure that I believe all that. I think it's all just all the cytokines that are released in our body from the glial cells, from the neuroinflammation we have with arachnoiditis and adhesive arachnoiditis. Your body just doesn't know what to do with it, and it causes just all these autoimmune disorders. But all of my tests for everything, lupus, Sjogren's, nothing was coming up positive. So my local rheumatologist couldn't handle me, and I asked for a referral to a teaching hospital. So U of Tennessee at Erlanger in Chattanooga was my closest place that was in network for me. But so I took it for the 12 weeks, and that I saw my primary care doctor and was like, something's just not right. I'm tired, but it wasn't the autoimmune tired, like I have to go take a nap or I'm not going to make it through dinner time. It was just a weakness, tired kind of feeling. And then the constant heartache. I didn't like that idea. So that's when I figured out it was the endothelial cells. And then my next step was, what do I do about it? And I was already taking vitamin C, which is an amazing antioxidant. So I got serious about taking it 4,000 milligrams daily. I try to spread it out through the day because you can only absorb so much of it anyway. And then researching found out that the L-Arginine directly provides nitric oxide to your endothelial cells. So I take 1,000 milligrams of that 6 times a day, staggered throughout the day. And now that heartache has completely stopped. My Raynaud's 24/7 has completely stopped. I see my local cardiologist, not tomorrow, but next Friday, because I couldn't get into there's 60 cardiologists in the United States that are certified in treating autonomic dysfunction and what it does to your heart. Luckily, there's one an hour and a half from me, but my appointment's not till January of 2026. So I've got to do something between now and then. But statins are supposed to help as well. But anyway, I wanted to touch on the autonomic dysfunction with the intractable pain that we have. Since we're talking about gabapentin and Lyrica, I could scream from the rooftops and shove it up every pain management doctor's derriere because it's a bunch of crap. It does not structurally similar to GABA, but it does not bind to any of the receptors or influence the synthesis or uptake of GABA. Same thing with Lyrica. It's just a newer form of it. The pregabalin does not bind directly to GABA A, GABA B, or any of the benzodiazepine receptors. They're not sure how it works. Frankly, it does not work. You got people taking 800 milligrams, 1,000 milligrams 3 times a day. And what it does is it actually supplies glutamate into your synapses, which is an excitatory neurotransmitter. Well, that's just what we need when we're having autonomic dysfunction. We don't need any more excitatory. We need Valium or Xanax that is a calming neurotransmitter. You've got GABA receptor A, which is where your diazepines bind to, and you have GABA receptor Bs, and that's where baclofen binds to it. Baclofen has been found, I've got a research article from 2014 out of China where they tested it, the GABA B receptors, and baclofen actually helps with the nitrous oxide synthesis and translocation for the endothelial cells. So luckily, baclofen and Valium was the first thing my primary care doctor changed me to in 2020 before I was even diagnosed with adhesive arachnoiditis, because my pain management doctor would not budge off of the Flexeril that I had been on for the past at that point, probably 12 years. She put me on baclofen and Valium for my contractures was the main reason for the baclofen, and then Valium for the other muscle spasms that I was having. And even now, my GABA is absolutely shot. I get 10 milligram diazepam pills every month, and I break them in half. So I'm taking 5 milligrams, probably 4 or 5 times a day, because that's the only thing that helps to calm my heart rate and my pulse. If I stand up and, just go to put a load of laundry in and then come back and lay back on the couch, I'll take my blood pressure and my systolic will be up and my pulse will be up. And then I'll lay down, take a Valium, take my blood pressure 10 minutes later, and pulse and everything's back down to normal. So there's no doubt that my GABA is shot and needs replacing, as well as I take 2.5 milligrams of Adderall, also about 3 times a day. And that seems to be enough to keep my dopamine receptors open to help my morphine to work excellent. I am so blessed that, yes, at the end stage of all this, and now my heart's messed up, but I'm not in pain. My pain's under control. So
You said a while ago something that I wanted to come back to. Did you come to this conclusion on your own, or did somebody tell you that arginine might help spinal fluid leaks?
I found a scientific article on the internet about it a few years ago, because I have the leakage from on my sacrum, and there's so many tendons and ligaments down there that have just ruptured away from the CSF leaks, I'm sure.
Are you convinced it helped seal your leaks?
Oh yes, I knock wood. I can't even tell you. It's been years since I've had an actual leak, and they always occur around L1, which was the last place they went in for CT myelogram, and at C6, where they've done 2 cervical epidurals, since I have cervical arachnoiditis as well. Both of those, if my pressures get too high, or like I twist trying to climb up into a high truck or something like that, I'll twist the wrong way and they would pop. But knock wood, I can't even tell you the last time that I had a leak.
Right. Did they tell you the mechanism of why the arginine works?
I don't recall. It's been quite a while since I read that article. I have it, of course, in my tons and tons of paperwork, but I assume it has something to do with helping with collagen, I would guess. I don't know.
Well, the reason why it works and why it's being touted as a cardiac drug these days more than anything is it does release or help manufacture nitrogen oxide.
Right.
And that dilates the blood vessels and brings more oxygen into the area. Okay.
Right.
Now, with adhesive arachnoiditis, the drug that's been the most popular to do that has been pentoxifylline or Trental. And what it does, it manipulates the shape of the blood cell to go through the vessels. And there have been reports, particularly out of France, and some patients even that I've had, feel that the pentoxifylline has helped. And arginine has started to be used with the pentoxifylline for that purpose. I can understand why arginine should help a leak, and And somebody else just flashed on the screen here, which I think is, again, something that really needs to be discussed, and that is the standard of the day in a modern medicine for leaks are blood patches. And that means, you inject blood into the spinal column.
Yeah.
And they even do that in cases that they can't find the leak on the MRI, but they do it because of symptoms. And I'm not sure that's all valid. But I would say this before anybody subjects themselves to blood patches these days or surgery for leaks. I mean, simple things like arginine, BPC 157, the peptides, the hormones, particularly HCG, certainly seems to me should be tried first, because it's just a matter of trying to heal the dura to keep from leaking. And so I'm glad you're bringing up arginine, because it has not been given much of a trial.
Right.
And you're one of the, in fact, you're about the first I know that's taken it in that dosage. You're taking what, 400 to 600 a day?
Six L-Arginine, I'm taking 6,000 milligrams a day.
Taking the 1,000 milligram capsule?
Yeah, 1,000 milligram capsule 6 times a day.
Yeah.
Yeah. Plus
Somebody
vitamin
flashed,
C and DHEA also helps raise nitric oxide.
somebody flashed something up on here that they heard that arginine causes the Epstein-Barr virus to propagate. I don't know that's the case. I don't know of any drug that propagates the Epstein-Barr virus. The Epstein-Barr virus, it works on low cortisone and stress. That's when it likes to propagate. Stress of any kind, trauma, infection, psychologic, the cortisol drops, the virus reactivates. I don't know that arginine has any relationship to the Epstein-Barr virus, at least as far as I know. A lot of stuff's out there in the literature and science that I don't know about yet, because an awful lot of people worldwide are very concerned about Epstein-Barr virus. So,
Yeah, because if you're, it's got to be acting as an antioxidant, just like vitamin C is. So that would be contradictory if it's supposedly making EBV worse to me.
might be making it a lot better.
Yeah, it should be.
Yep.
Yes,
Because you're getting oxygen into the tissues.
exactly.
It's growing. I mean, Epstein-Barr virus likes to, thrive in malnourished tissue that doesn't have any oxygen, tissue that's not exercised. So, it likes to go where things aren't the best.
Right.
Mark, do you have some questions for this young lady?
Will you be my mentor?
Sure. Absolutely. Absolutely.
Yeah. No, you know more about this stuff than I do, and I respect you the hell out of you.
Thank you. Well,
Yeah.
I have a veterinary background, so working with animals who couldn't speak, our job was to put the pieces of the puzzle together and always asking why. Just like getting a diagnosis of fibromyalgia. Okay, well, what is fibromyalgia? Okay, so why do I have inflammation in those areas of my muscles causing me pain? Why? Fibromyalgia is a scapegoat diagnosis.
Yeah.
What's the reason behind it? Let's figure that out and treat it.
Yeah, you bet. Alison, while you're here, you've also been a real advocate. Your family's had EDS. You've been outspoken on not just the medical part, but on some of the political parts. And I talked to Dr. Ibsen earlier today about an issue that I want to bring up to you and to him and everybody else. And maybe I'm overreacting, and I even hate to bring up what I'm about to bring up. And the reason I hate to bring it up is that I've been a great fan of something called the AARP Bulletin. Now, the AARP is a senior citizens program. They are tied to United Health and do their Medicare. So they are, unfortunately, they are insurance, the company.
Yeah.
And they put out this latest bulletin, and the headline says, where have all the doctors gone? And they've got 3 or 4 pages in here about that people can't get medical help and it's got to get worse. Okay? And particularly if you have an unusual condition of which people watching this show happen to have. Now, this article on lack of medical care was bad enough. But then I happened to leaf through it, and then a little short article caught my eye. And I'm going to read this to you, and I hate to read it to you because it's just terrible. And I'll tell you why, and I think you'll grab it. It's an article here, and it says, entitled, Chronic Pain Surges Among Those 65 Plus. Now, I'm going to read you the first paragraph. Listen very carefully to what is written in this prestigious magazine by a prestigious and needed organization, and one that I've championed, and I hate to bring it up because I've been a fan of AARP. But this article has got to come forward on what they've said here. Let me read it to you. Listen carefully, everybody. Chronic pain has reached alarming levels in the U.S., with nearly a quarter of Americans saying they have a discomfort that had an impact on their daily life or work activities in 2023. Now, here's the kicker. An 8.5% reporting high impact pain. Now, listen up, folks. Defined as pain that can cause opioid misuse, anxiety, and depression, according to the Centers of Disease Control and Prevention. Now, what they have said here now is that high impact pain in 25 million people means you're an opioid misuser. That is the definition. In other words, what they've done here, they've said that high impact pain and opioid misuse are the same thing. And they say that that is in writing from the federal government. Okay? Now, I'm hoping that this was a junior journalist that wrote this. I'm hoping that it didn't mean what they've written here. In other words, what they have done, they said that if you have high impact pain, you are an opioid misuser. Okay? It doesn't give you any leeway, but they don't say that high impact pain ought to be treated or people should get good care. They're saying that it has you're an opioid misuser, and they say that it comes from the federal government. Now, here's what I'm asking you and everybody else, and I want Dr. Ibsen to say something about this. I cannot believe, and maybe if I'm wrong, I want somebody to show me this now. I want to see where the federal government, the CDC, has said that high impact pain is defined as opioid misuse. Okay? I want to see if they actually wrote that somewhere. If they did, that's a travesty. The mere fact that it's here is a travesty because here's the way I look at this thing. What they're doing is they're telling doctors right here, don't prescribe opioids. Okay? And they're also, worse than that, they're saying that this is an excuse for doctors to take you off opioids and not feel bad about it. Now, they also are worried about where a doctor's coming from. I think any ethical doctor who would read this would say, you know, this medicine's just getting to be too much for me. They're telling me I can't even prescribe an opioid to somebody with high impact pain.
Yes.
You see where I'm coming from?
And that article states that that many people over 65 are having that much pain that affects their daily living.
They're saying here it's the whole population, not just the senior citizens.
Yeah.
Be fire higher with the over 65, but they're saying here it's 8.5% of the whole population, which would translate to 25 million people. 330 million people in the country, 8.5% is about 25 million. Okay, so this statement here really has to be, is this a typo? Is this a junior journalist and nobody decided to proof? Is this a malignancy put out by United Health Insurance Plan through their subsidiary called AARP? In other words, I really think that any of you out there who want to help advocate, Jamie, I'll get you the address of where you write to, but and I want to challenge that, man. I want Mark to come in and weigh in on this. Does anybody believe the federal government has put that in writing, that they define high impact pain as opioid misuse, depression, and anxiety? I mean, that's what this says. So at any rate, going forward, the only thing I guess we can do is stop using the term high impact pain. So we have to. Mark, weigh in on this.
Okay, I am ready to weigh in. So I don't think it says that. I don't think the government has said that. And this goes back to the CDC guidelines of 2016, which were widely misinterpreted and were rarely read, in the same way that the HIPAA regulations haven't been read, in the same way that the empowering legislation for the Affordable Care Act was never read by anybody. People don't read these massive outputs, but what they do is they say, well, there must be something in there that's telling me to do something to avoid badness, so I'm going to avoid the badness. And this is basically a very basic statistical association. That is to say, association does not mean causation. So, of course, people with high impact pain use a lot of pain medication. Duh. And so and so that's the only implication that can be made. Not only that, but I was taught, and taught well, in my opinion. I'm, the thing about science is it can keep teaching you if you keep listening. But what I was taught is that the only pain medication for the elderly is an opiate. And that's because opiates don't cause GI bleeding, liver disease, kidney failure, congestive heart failure, stroke, et cetera, et cetera, et cetera. So opiates are the safest thing for the elderly population, and the only thing that should be used in anybody over 65. Anybody over 50 who's using a non-steroidal is risking their kidneys and their stomach lining. So I'm saying that it's an association, not a causation, and the typical misinterpretation of an amateur journalist who's not doing their due diligence, and we know what to do about that.
Okay. All right. With that, we are coming to an end. And again, I want to encourage everybody to let's not let any writing like this go by anymore, because if we don't speak up, it's just going to cause more. And we don't need to throw arrows or anything. I'd like to say, where did this come from? And is this what you meant? In other words, my guess is they'll say, no, that's not what we meant. And I don't think the federal government put this in writing. I don't think they're going to define high impact pain as opioid misuse.
But patients all the time encounter their doctors that says, oh, there's a law that says I can't prescribe this to you.
Yep, absolutely.
It's just an economy of speech. People are in a hurry to get out of the exam room, and they're not willing to get into these conversations.
You bet. Well, to close this
Dr.
out.
Tennant, one more thing.
Sure.
One more thing, Dr. Tennant. Cora just said that pain medications are an anti-inflammatory as well. And I don't know if there's a direct anti-inflammatory effect by taking an opiate, but the indirect effect is that your cortisol levels are lower, and therefore you're getting less inflammation because you're under less stress. Do you have anything to say about that?
Oh, the first thing you want to do if you want to maintain your hormones and you want to suppress the Epstein-Barr virus, you've got to control pain, because pain drives down your cortisol, drives down your DEA, drives down your progesterone. And so indirectly, pain causes inflammation, and opioids relieve it. It's an indirect mechanism, but it's there. And that's also, you got to have opioids to feel good enough to get out of bed, to eat, to exercise, to socialize. So this idea that opioids don't help inflammation or pain or your diet is not true. You got to relieve the pain. And the bottom line is severe pain reduces the very hormones and neurotransmitters that reduce the inflammation. Okay?
Yeah.
So step one in these diseases, you got to control the pain before you can control Epstein-Barr virus and the autoimmunity and everything else. Okay? So let's go with that. Oh,
Thank you.
and I'll close that again with my soapbox. I can't find anybody who ever got hurt with a 2 or 5 milligram Valium, and nobody ever got hurt with ashwagandha. In fact, a lot of people have probably got some help. With that, thank you everybody for being here. Let's keep up the advocacy plus the science. And anyway, we're going to have to give Alison Guyton a new PhD.
Well, she does have a PhD. She's got a lot of data, and it's filed higher and deeper.
You bet. Again, Jamie, thanks so much for putting us on. Mark, Allison, you've been great.
Thank you.
We'll see you next week. Good night.
Thank you.
God bless us,
you.
everyone.
Thank you.
Good night.
Here's the issue here. You know, we Mark, all of us we'll put out the science, we'll put out the letter. The real tragedy in this whole thing is this the type of garbage that gets into the lawyers take, that gets into prosecution, that gets in the federal court system, that gets before a federal judge who doesn't know a doggone thing about medicine, and these lawyers that come in. And the reason because it's my favorite thing, the reason they became lawyers because they weren't good at math and science. And this is where prosecutors can use, I'm preaching this morning. I'm starting to, I didn't mean to preach.
Hallelujah.
But prosecutors are beginning to use this type of rubbish so they can hire what we call hire legal with them so they can get to become federal judges. This is the kind of garbage that we have. I'm trying to lecture here, Mark. I'm trying to lecture, but I'm preaching. This is the kind of garbage that we need to put a stop to. Thank you very much. I appreciate it.
Thank you, Beth. Thank everybody. Well
Good
done.
night, everyone. Thank you so much, Pastor Norm.
No.
Pass the basket.
No, I'm trying to lecture you. Trying to lecture.
You did a great job. We'll see you guys next week. Okay.
Love
Much
you
love
guys.
to all of you.
Love you guys.
Freedom
is making some headway. We're getting House Bill number 2. It's going to be introduced, and we're getting everyone to vote yes. I'm getting in touch with my legislator to vote yes on it. But we're going to get things changed.
Very
Yes.
Medical freedom. And I suggest everyone get in your state and find some sort of medical freedom in your state that advocate with them, and they will give you a voice. Trust
Say
me.
it, Brandon. Medical freedom. That's right. I love you guys and God bless you. We're out of time for tonight, but we will catch back up next week. See you all then. You're not alone.
Bye.
Bye.